arborization of a tree as if you pour, gadolinium in the ductal system. So I think this is a good example of non-mass enhancement segmental. There it is. That's the correlate to her cancer and to her calcifications. Here is a clip with the node, and and this is a clip of the parenchyma after the unsuccessful ultrasound-guided core biopsy of the cows. This is the port. Okay, remember she is going to be on the contralateral side now in patients going on neoadjuvant chemo. So does she respond well? Yes. The node is smaller, almost completely resolved before chemo, after chemo. How about here? Before chemo, after chemo. Okay, she did respond well. And here is the clip from that biopsy attempt. Before chemo, after chemo. It's hard to see, but her segmental non-mass enhancement also responded well. So it's all good, okay? But good response in the breast and in the axilla. What next? Surgery. But where do you excise? Remember, we haven't proven with tissue diagnosis, with biopsy, that there is cancer in the breast itself. Okay? So what happened is that the surgeon says, do something. Okay, I want you to prove it is in the breast. So what we did at this time is that we brought her back and we attempted stereotactic guided core biopsy of the calcifications. Okay? So these are air from the core biopsy of the calcifications, not done stereo. Her breast was thought to be a little too thin, but it turns out that you can kind of oblique her and put a pad underneath, and it was thick enough for the successful core biopsy. And this is the clip that was placed after the stereotactic guided core biopsy. Here are my specimen radiograph for the biopsy of the calcifications. Are there calcifications? Okay. Here and here, so I sampled them, which is not something we did for the ultrasound-guided part. In fact, they are in multiple core samples, as shown by the yellow arrows, but now we got fibrocystic change. Once again, is that concordant? Now, why is it because we just are not good at biopsy? Is it not pathologists? What's happening here? Why do we not get cancer now? We had chemo, right? The whole world has changed now. So we did our best, but statistically, we were going to get cancer, given the chemo, given the response. And so, kind of interesting, this patient chose not to have surgery. She chose only to have whole breast radiation, and she's doing well. Okay, that was kind of a personal choice. So she chose whole breast radiation instead of surgery. All right, 55-year-old screening. Again, I'm showing you a whole bunch of fatty breasts too, to show that there are lots of lessons to be learned, and that we have to have a lot of respect for the mammograms, not only the dense, but also the fatty. Okay, year one, and whenever I show a year one versus year two, I'm going to say that year one, we don't have a cancer yet. Fatty breasts, MLO and CC, year two. And there is a cancer. And we saw this prospectively, true life story as I'm presenting it to you. Okay? I'm going to put them side by side. Do you see the cancer? Where is it? Outer or inner? Outer, posterior, anterior? Posterior. Stop me when we get to it. Yes, warm and hot. Okay? So here it is now. Something that wasn't there before stands out new. Could be summation, could be, the way, but because I'm presenting it as a teaching case, telling you there's a cancer, that we're going to be focusing on that area. Always, always, always look for the correlation in the other view. On the screening view, that happens to be MLO. Okay? Say stop. Ish. Okay. So that it is. Now we know, small, subtle. I like to call that my favorite word, developing asymmetry. You thought it was patch, right? No, but developing asymmetry is my favorite word. So we recall her by red 0. This is her diagnostic evaluation, 90-degree lateral, MLO, and CC. So again, a lateral lesion, L for lateral leg falls. This is all consistent. And this is important, so then we know exactly where it is as a correlation to look for on MRI and when you do ultrasound, where you place the transducer, okay? So this is going to be kind of a mid-outer posterior breast, very small, less than a centimeter, and it's against fatty tissue, okay? And the lesson, too, is that with ultrasound, it is more difficult to see cancers in fatty tissue, okay, than in dense tissue. So the opposite with mammography. Has to do with sort of the physics of ultrasound. Cancers are hypoechoic. Dense tissue is relatively hypoechoic, so it's hard to see. So the opposite situation from the masking effect of mammography. Okay. So of course, though, we're going to do ultrasound. But before we did that, I just want to prove to you once and for all that this is a real finding. We see in 2 views, spot compression did not go away. Margins a little bit irregular. The interval appearance makes us suspicious already. We did not see anything under ultrasound, however. No sonographic correlate to the mammographic finding of developing asymmetry. Can you stop? You're like, well, I'm really good at ultrasound. I do this a lot, and I see a lot of cancers. And ultrasound, of course, is one of our really good friends in breast imaging. But no, you cannot stop in this case. We're not sure about MRI or contrast-enhanced mammography or anything else at this time. But with ultrasound, I know that we should not stop just because you don't see it. Okay? Especially in this breast, which is fatty, especially in that area, which is quite fatty. So we did an MR, and is there a correlation on MRI? Right here, the blue circle. Okay, that's a little blue cancer. Posterior, central, the shape, the size, approximately what we saw in mammography. And on the sagittal, yeah, there it is. Or yes, there it is. Okay? Nicely correlating with the mammogram, right? I like these correlation cases. Here is the sagittal, post-GAD, fat-static, and here is the initial mammographic finding. So that's a good correlation. Size, location, the appearance. But what I find remarkable about this case is that there is another cancer in this same breast, fatty, that we did not see prospectively. Okay? We did see this small one, but did not see the bigger one. And the bigger one we saw when we did the MR. Okay? Which is shown here in the orange. And another look at the orange circle. There it is. Spiculated enhancing mass. And look at how dramatic that is on the sagittal view. Right there. Okay? Spiculated, homogeneously, strongly enhancing mass. There it is. Where is it on the mammogram? There's some stuff here. But again, true story is that we didn't think there was that much change. No mammographic correlate to second anterior MRI finding in the lower outer breast. Okay, I'm going to show you. Is there a lot of change here? I don't think so. I mean, prospectively, we didn't see it on the story, and we did see the posterior one. We didn't think there was a lot of change. And is there a lot of change from year 1 to year 2? Not something I would say, but it's so dramatic on the MR. I mean, I know some of you say, maybe that's it, but again, I'm trying to not just say, oh, look at that, look at this, but kind of go through with you real-life settings that hopefully are useful to you, when you go to the clinic. So what is the most appropriate next step now? Is a short-term MRI follow-up, as cancer is very unlikely in the absence of a mammographic finding. Just, go along with my conclusion that there's no mammographic finding, even though some of you may disagree with that. Second look ultrasound with ultrasound-guided core, MRI-guided core biopsy without second look ultrasound, or MRI-guided wide localization of the surgical excision. I'm talking about the anterior lesion. 1, 2, 3, or 4? 2? Yes. Thank you. Year 2. Definitely not 1, right? That's a really suspicious finding. Just because you don't see it on mammo, or just because you may agree with me that we don't see it on mammo, doesn't mean that it's not a cancer. It's clearly a cancer. We talked about this paper already, and here is the MRI correlate. Really easy peasy, lemon squeezy. Okay, nice second look ultrasound. It is that. Here it is, it's hypervascular. You can cord under ultrasound because you can see it well. Prenatal deployment afterwards, and this is an invasive ductal. This here is a little clip, okay, that we want to ascertain. And there is the initial finding on the mammogram, blue arrow. There is the clip from the second look ultrasound-guided core biopsy of the MRI detected lesion. Again, I don't really see a mammographic lesion myself. And this here, we then biopsied. How did we biopsy this one? We don't have a correlate here. We did it under stereo, okay? And that's a stereotactic guided core with more air after the stereo. And this gave us a diagnosis of multifocal disease, both invasive ductal carcinomas. And another teaching point is just because we don't see this one, the blue one, doesn't mean that we won't see the orange one under second look ultrasound. Remember, it's bigger, right? And one of the rules is size, pretest probability, and mass versus non-mass enhancement. And if nothing else, the orange MRI finding, it's bigger. Okay, and I think it's a mass. Okay, any questions? Okay, so this one, I just a 69-year-old. I didn't give you her symptom because that'll kind of give the story away. These are her mammograms when she presented. XCCL, CC, and MLO. What do you think? A finding, dense breast. Here's her MR. This is a MIP image. Is this, what's abnormal? Side 1 or side 2? 2. Okay, what's going on? Lobular carcinoma, maybe a lymphadenopathy here. Okay, all this is constellation of the side. This is the subtraction. I just want to show you these, which we haven't seen yet. These are curves. These are classic type 3 washout curves, going up but then quickly going down because of the principle of angiogenesis. Very similar to what was discussed with contrast enhancement mammography. And this is more in the chest wall area, just showing that there's likely involvement of the chest wall, as shown by the enhancement here. Okay, that I'm pointing to. These are source images. I just want to show you that you can do coronal reconstructions. But what is this? If there's one thing that strikes you in this case, what is that? I heard someone said skin. Is that thickened? How thick is thick? That's thick, right? Okay, someone said 2 millimeter. Yesterday in the MRI talks as being too thick, but this is thick. What is the single most likely diagnosis for this patient? Congestive heart failure, diffuse DCIS, inflammatory breast, or Paget's? 3. This is a pretty classic inflammatory breast. I didn't give you infection as a choice. It doesn't really work with infection with all the imaging findings now, but it's more than CHF. You will see kind of bilateral findings, which we don't have in this case. And inflammatory breast is the single best answer with the skin thickening. And just to show you her course is that this is her pre and post. Pre what and post what? Chemo. Okay. So pre-neoadjuvant chemo and post-neoadjuvant chemo. So the lymph nodes have responded and much of the breast has responded as well with this kind of single enhancing focus remaining. In these cases where the initial cancer is so large, likely you will still do a mastectomy, but the point is that now you have reduced the tumor burden, easier for the surgeon, and there is evidence that by the fact that she responded gives you prognostic information. Okay? And also the chest wall, remember the chest wall right here, has also responded in a good way, in a positive fashion. Okay. I think, let's see, I have it to 245, correct? Okay. So let me breeze through this one. 81-year-old palpable lump. You do ultrasound. Why? I don't want that mammogram because it has radiation. Okay? So don't give me the mammogram. Okay? So give me just the ultrasound. Yes, you're 81, man. You don't have to worry about the radiation. No, I don't want the mammogram because I read in the New York Times it gives you cancer. So palpable lump, ultrasound. What do you think? Story gets a little more complicated because she generally doesn't really believe in imaging. Went to her doctor first, she's seen for 60 years, I'm exaggerating now, 30 years, and who tried to do an aspiration and got a lot of fluid out. So say, oh, good news, Mrs. Smith, Mrs. Jones, this is just a cyst. Well, is this just a cyst? There's a lot of stuff going on here, right? There's some cystic parts. How patient got an aspiration, got non-specific fluid, is this a cyst? The BI-RADS will say this is the older BI-RADS complex cystic mass. The older BI-RADS will say complex mass, okay? But the new BI-RADS now says this is a complex cystic mass. What's this? Calcifications. So this is a mammogram. Quite dramatic, right? Okay. I'm going to go through this case real quick now just to show you all the images. Within the mass itself, there are calcium particles. And these calcium particles, morphology, linear, distribution, linear, they're suspicious. This is our MRI. What do we think about this? What is the enhancement characteristic? Rim enhancing, right? That's a suspicious word. Delayed looks like this is persistent. Does that mean it is not a cancer? No, because you could definitely have a cancer that's persistent. T2 shows intrinsic hyperintensity. I already showed you a case of a necrotic lymph node. And the most likely diagnosis here is abscess, hematoma, fibroadenoma with necrosis, or IDC with necrosis. IDC, okay? Abscess and hematoma, while those things can happen, they can look like a bunch of things, Abscess is too early. She just had her palpation-guided biopsy, aspiration by her clinician. She didn't act infected. And the hematoma is not likely because of what? Morphologically here. Imaging-wise here. Enhancement, great. Also because of the mammogram showing calcifications. These are classic malignant-looking calcifications. So again, putting all the pieces together, this is invasive ductal necrosis. Okay, and here she is again, pre and post neoadjuvant chemo. Okay, let me jump ahead a little bit again for the sake of time. We don't do this a lot in our institution, but I did want to show these cases. Dr. Rasha asked me to talk about this a little bit specifically. 45-year-old palpable lump. There's a palpable lump on mammogram. Anything else? Down there, okay. I didn't show you the CC because I marked it and couldn't take it off the images in time to get on the plane, but yes, she has two masses. This would be multifocal or multicentric if they were both cancers. Centric because two different quadrants. Here is the ultrasound. Heterogeneous, both hypoechoic and echogenic. A little bit increased vascular Doppler. Now, if I show you these alone, you can say, could that be an abscess? Yes, it very much could have been. The mammogram doesn't look like it so much, but most, because she doesn't have any inflammation of the skin, anything else, but most importantly is that she didn't present that way clinically. Okay? So even though these images very well could be an abscess, she did not present that way clinically. Here is her second, smaller mass, looking very analogous to the bigger palpable lump. And this is her MRI finding. Type of enhancement, lesion 1, which is the bigger one. I'm going to say rim-ish. Okay. Maybe heterogeneous, some of you may say, and that's a clip, of course. Lesion 2. What am I showing you here? Lymph node with a clip. Okay. So these are our MRI images showing enhancing mass. I would say irregular shape, heterogeneous / rim enhancements, how would we give it? And early and late subtraction. Okay, so this is again kind of type 1 persistent. It's filling in with the late. Okay, more rim-like in the early. Yeah? Okay, so these are pretty good examples of a rim-like and rim enhancement, and it's not consistent with an abscess because abscesses don't fill in this way. Okay, abscess tend to be rim enhancing and rim enhancing only. So aside from the fact that she did not act infected clinically, are these MR images, which is more consistent with a mass, a non-infectious mass, as opposed to an abscess. Is that clear? Okay. All right, but what about these images? What are they? Diffusion. Okay. I have to confess that I don't really use a lot of the diffusion information for me in everyday work, but we do it in some cases, and we did in this case. There's a bunch of background, but you can see that the lesion 1, the bigger one, lesion 2, the smaller one, show certain signal characteristics, which is my question. What are the characteristics that the diffusion image is most consistent with? That these masses are malignant, indeterminate, or benign. Going back to the diffusion. Lesion 1, lesion 2. They're bright. Is that malignant or benign? Or I just don't know. They're malignant, right? And this is meant to be a malignant, you know, the mammogram, the ultrasound, the MRI, everything together. And that this is just a classic cancer, something you read about in the textbooks, okay, not so difficult, that they're bright. And probably a long story to explain the physics, but in short is that in cancers, that the histology of it is such that the water movement is more restricted, and the signal characteristics are inversely proportional. That means more restricted will look brighter, inversely proportional. So bright on diffusion tends to be more likely to be malignant, in a nutshell. Okay? So these are consistent with malignant. These were multicentric invasive ductal carcinomas in this case. 17-year-old, multiple palpable lumps in one breast. Which is the breast with the palpable lump? The right. Here it is. Okay? This is early, and this is late. Okay? Early and late. You see this one mass? What do you think of the morphology? Circumscribed. Okay? She's got a lot more of them here. And you see these are the subtraction images. Look at this. 6 masses at least being measured. And this is several areas within this one mass. That's her most palpable, the largest, and the most anterior and superficial. And here are her various projections in terms of axial, sagittal, and coronal. Okay, just again to show you the images of what they can look like. Their masses, I would say circumscribed, I would say round and oval, enhancement characteristic, homogeneous, and I think I showed you the early and the late. So the curve, I mean, if you were to get a curve, would be more type 1, and indeed here's the curve, type 1 kind of going up. Maybe a little bit plateau, some of them, but you do not have washout. Again, just to remind us of what the curves look like. Again, more curves. Okay, this is of that particular mass. Ultrasound. Masses. Masses and masses. And I actually don't have a question because I'm not sure what to ask. What would you do with this case? Let's have a discussion. What would you do, Dr. Ashraf? 17-year-old, because you can imagine she's upset, her mother's upset. Yeah, it's just tricky, right? Do you just, I would say not surgery, okay? I would say do no harm. My gut feeling is that these are benign. So my conclusion was to say that actually this is a counsel case someone had given me from another part of the United States. So I would advise discussion with the patient and her family, how nervous they are or not. Even if they're nervous, I would advise against surgery in this case. I would say do a core biopsy if they're nervous, or just watch if they really don't want to avoid the needle. My gut is these are all fibroadenomas, right? They look like fibroadenomas. All the characteristics, ultrasound, etc. Her age group, she wasn't particular, genetic syndrome, leishmania, or anything like that. She wasn't a BRCA family or anything like that. So we offered her a core biopsy, and I think that's what she's going to do, at least of the largest lesion, or the one that's most easily assessed. And I want to talk about this in a setting of some work we did in San Francisco, once again, back in 2000 now, the multiple bilateral mass detector on screening. And I'm very proud of this work because it has implications for other types of work downstream. I know with screening ultrasound, that fact that you see cysts everywhere, okay, or even solid masses everywhere that look alike, we can safely call BI-RADS2 in the majority of circumstances, because multiplicity, bilaterality, and similarly a pairing suggests validity. Okay. So this kind of, it's been discussed earlier, before 2000, that kind of set the way for that we now apply to screening ultrasound, and certainly screening tomosynthesis, where we see a lot more masses than before on the 2D mammography. And again, perhaps, and also on the multiple foci and MR, perhaps one day, in the contrast work that many of you are doing as well. Like, a lot of them, they're all circumscribed, maybe that's all okay. Case 15, this is a little companion case, because she's also youngish. I think she was like 30, 31. That's young, okay? Really young as I get older myself. So longitudinal transverse. So what we have is a Doppler, corresponding, this is a palpable lung, again, because she's young. I think she was like 29. She did not get a mammogram. What do you think this lesion is? This was actually invasive ductal carcinoma, a gravid patient. She was pregnant, M29. And I'm showing you to show you another reason, just kind of a fun case. This is invasive ductal in a postpartum patient now. Now, why is she gravid and why is she postpartum? Like, what happened? Well, she gave birth. Why did we wait until she gave birth to do the MR? Can you do MRI in pregnant women? Yes? Why did we not? Can you do breast MRI in pregnant women? Belly, okay. We're at the belly. I mean, we do in pregnant women. In fact, we have fetal MR, right, as a field. So obviously, we do MRI on pregnant women. The belly could be tricky because you're lying prone, but I think the single answer here is that with breast MR, we need gadolinium. We need some sort of contrast agent. And gadolinium is a relative contraindication. Some may say an absolute contraindication because gadolinium has been shown in animal studies to cause birth defects, teratogenic effects. Okay, so it's always benefits versus risks in patients, and at least in the setting of breast MR, the benefits do not exceed the risk. So I would say we almost never do breast MRI in pregnant patients. Okay, so she was close to, it's the third term, close to delivery, and this is her after her baby was born to take care of her diagnosed invasive ductal carcinoma. So breast cancer in the gravid and postpartum patient. So this is actually the mass that's enhancing very strongly. That is her invasive ductal. But I'm kind of showing you the case to show you another finding, which is kind of interesting. There is the cancer, but what am I pointing to with the yellow or the orange arrows? What is that? Pre-GAD, post-GAD. Does it enhance? No. Let's look at other STIR. This is a STIR or T2 weighted image. This is T1 weighted, non-fat SAD. So it looks like that on the STIR. Doesn't look like cyst. It's not bright. But it is kind of bright on the T1 non-fat SAD. Or maybe it's kind of fatty because it's the same signal as fat. So non-enhancing, hypo-intense on STIR, and hyper-intense intrinsically on T1 non-fat SAD weighted images. What is the most likely diagnosis? Cyst, multifocal cancer, galactocele, or fibroadenoma? Galactocele. Oh, I did the wrong thing here. I meant to say galactocele. So this is meant to be blue here. Okay, not fibroadenoma. This fibroadenoma do enhance. It's not a cancer and it's not a cyst for reasons we already discussed. So there it is, and that's galactocele. Okay, so it's galactocele. Okay, last case. Goodness, we're actually going to be on time. Okay, so MLO, and I've shown this case, I think last time I was here in Egypt, and I'm just going to show it once again as sort of a conclusion. Okay, so circumscribed mass, palpable. How did you think this patient presented? Palpable lung? She actually had a palpable thrill. Okay, those of you, I don't know if you've seen. I've never seen one in the breast until this case, but it goes shh, 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 kind of like an AV fistula in a hemodialysis patient. Okay, it was very dramatic. It was in the AV fistula. It was in the AV malformation. This is her ultrasound. Circumscribed mass. It was very vascular. Okay, and here's her MR. Pre-GAD on the top left, post-GAD and delayed. Heterogeneous enhancement was a homogeneous with perhaps some non-internal subtations, non-enhancing internal subtations that filled in type 1 persistent kinetics, oval mass, circumscribed, so we're still kind of thinking benign, but this is an AV fistula or AV malformation. I wish I had a video of the presentation, but I don't, but it really sounded like it was a palpable thrill. And here is her MRI images, in the sagittal and the axial, lots and lots of feeding arteries and draining veins, perhaps. Okay. Again, all the images put together, compiled now. What is the most likely benign diagnosis? Let's say this is not a cancer. Okay. What is going to be if it's going to be benign? Is it a solid mass? Histology to be determined. AV malformation, AV fistula, and those because of the way she presents. Abscess, hematoma. Both AV malformation and especially AV fistula has sort of classic Doppler appearances, which we do not have in this case. This is most likely a solid mass. Doesn't look like an abscess or hematoma of the enhancement characteristics. Okay. In fact, what I'm describing to you, if you weren't seeing the images and if you didn't have this palpable thrill as your clinical finding, you probably think it's a fibroadenoma, right? And indeed, when we biopsy, this was a fibroid tumor. Okay? And kind of the cool thing is that when we did core biopsy, this had 50 mitotic indices per high power field, so it's quite aggressive or high grade, if you will, phylloides. And the surgeon didn't want to embolize, didn't want us to take it out because she was afraid of bleeding. So we were asked to preoperatively embolize it. It's a vascular phylloides. Have to confess that we didn't do it. The IR guys did it, and or gals. I don't know guys or gals who did this case. Is that this is a selective injection of a accessory vessel to the breast mass itself, right here. Okay, we're doing this angiogram going down the subclavian, and this is selective injection.